You mentioned cholesterol earlier, and that was certainly a risk factor. What do you think about statin drugs? Is that good for some people, or, you know, because they're often prescribed quite liberally?
Yeah, some people call them Satan drugs or statin drugs because there's such a rift. Interestingly, if you get into academic medicine, 98+% of academic cardiologists, talking, you know, journal editors, and the idea that they're all being paid off by the pharmaceutical company is nonsense. You know, 7 of the 8 statins on the market are generic. They're free. They're $4. We don't go to Hawaii anymore because of Lipitor, because Lipitor is a torvastatin. It's basically free. So yes, there is still money in researching new lipid-lowering agents. There will be a new one called bempedoic acid out within the next 12 months. But the idea that people aren't motivated by scientific pursuit is largely hogwash. The buzz with statin prescription is risk assessment again. And in 2005, a society was formed, Society for Heart Attack Prevention and Eradication, SHAPE. They proposed, we're doing this crazy in cardiovascular medicine. Your cholesterol is 220, your gynecologist is handing you a prescription for Lipitor. We have no idea if you have the disease. Why are we treating a piece of paper? We don't do that with chemotherapy. We don't say, maybe you've got a lump in your breast, let's give you, you know, a tamoxifen. We don't do it that way. So they proposed, do a test for atherosclerosis. Look at a carotid and do a carotid intimal medial thickness ultrasound. Do a CT scan for calcium scoring. This was 2005. If they show no atherosclerosis, we're not doing prescription drugs. We're not doing statins. We're talking lifestyle and reassurance. And if it identifies an unusual burden of silent atherosclerosis, throw at it what you need. And it might be statins if 3 to 6 months of aggressive lifestyle and weight loss, and perhaps some supplements if you're so inclined. That has come to be now endorsed 13 years later. In November 2018, the American Heart Association put out new preventive guidelines, and they included pretty clear language. If your physician is handing you a prescription for a statin and you believe that you have no cardiovascular disease, find out, do an atherosclerosis test, do a calcium CT heart scan, do a CIMT. If you're a 0, say thank you very much, I don't want a statin. In my practice of advanced preventive cardiology, I have patients on statins because there's no other thing I can do, from restoring their gut to healing their liver to removing their metals to changing their diet to reducing their inflammation to trying natural products, of which I favor berberine and bergamot and red yeast rice and occasionally niacin, whatever it is. They'll go on a statin with mitochondrial support, and I see their plaque improve. They are very useful drugs. But I'd like to try all measures first. There is now pretty much a standard. If you're a cardiac patient hospitalized, you'll go home on the highest dose of a statin, and nobody mentions, you know, you might want to readjust this in a month or 2, or you might actually try to apply lifestyle and other measures, get your omega-3 levels in your diet up and such. So these people, unless they happen to fall into my office, will be on 80 milligrams of a statin for years. That's not appropriate. That's overdone.